My name is Brianna Lipscomb, and I, along with my co-panelists, Carla Torres and Nikia Grayson, will take a collaborative approach to moderating today's session. Just a reminder, this session is Reproductive Injustice, Inequities in Infertility and Maternal Healthcare Access in the U.S. This presentation will discuss infertility and maternal health as part of the full spectrum of reproductive health and propose policy recommendations on how to ensure equitable access to care for communities disproportionately impacted by infertility and maternal morbidity and mortality. So without further ado, allow me to introduce our speakers for today's session. Next slide. Great. So our first speaker will be Carla Torres. She serves as Senior Human Rights Counsel at the Center for Reproductive Rights, where she develops and leads the center's U.S. work on assisted reproduction. Using a human rights framework, she advocates for the destigmatization of infertility and for equitable access to infertility care, including IVF, for the rights of all parties to surrogacy agreements, in particular the rights of persons who act as surrogates, and against embryo personhood arguments that seek to undermine access to infertility care and reproductive freedom more broadly. I will be the second speaker. So as I mentioned, I'm Brianna Lipscomb, Senior Manager of the U.S. Maternal Health and Rights Initiative for the Center for Reproductive Rights. I have over 15 years of public health experience, and in my role at the center, I develop advocacy strategies to promote Black maternal health, particularly in the South, by mobilizing a broad base of stakeholders to advance state-level policies that further reproductive rights as human rights. I also serve on the board of directors for the Black Mamas Matter Alliance. And our third speaker, Dr. Nikia Grayson, is a reproductive justice informed public health activist, anthropologist, and family nurse midwife who has devoted her life to serving and empowering people in underserved communities. Nikia is the director of midwifery services at Choices Memphis Center for Reproductive Health, where they have opened the first nonprofit comprehensive reproductive healthcare center in the country and the first birth center in the city. She also serves on the board of directors for Sister Reach, the only reproductive justice organization in Tennessee. Nikia is passionate about being a disruptor to the current healthcare system and creating new models of care that integrate midwifery and center Black and Brown communities. She works daily to ensure all persons have the rights and means to make decisions regarding their sexual and reproductive health. Welcome, Carla and Dr. Grayson, and I will now turn it over to Carla to start the formal presentations.
Thank you, Brianna. Hi, everyone. My name is Carla Torres. As Brianna mentioned, my pronouns are she, her, ella, and I'm really excited to be here with you. Before we begin our session, we thought it was important to explicitly acknowledge the long history of reproductive oppression our communities have experienced in the U.S. Reproductive oppression is known as the controlling and exploiting of women, girls, and individuals through our bodies, sexuality, labor, and reproduction. There's a long history in the United States of federal and state policies that have targeted not only women of color, but also the ability of other marginalized groups to make reproductive decisions for themselves. These policies have manifested themselves in our communities' forced sterilization, non-consensual participation in medical experiments and studies, criminalization of pregnant persons, and other human rights abuses. All of these have wrought unimaginable harm on our communities, and not surprisingly, they've created in us a deep mistrust in our government and in particular in our healthcare providers. Additionally, this form of oppression, alongside other forms of oppression and discrimination based on things like race, gender, sexuality, class, ability, immigration status, and other factors, have historically resulted in power, privilege, and resources for a select few, and very limited access to power and resources for a large majority of us, including Black, Indigenous, and other women of color. An example of this is what is known as stratified reproduction, where some communities are encouraged to reproduce and have the resources and support to facilitate that, while other communities do not. My co-presenters and I will be speaking about racial disparities in our communities with regards to incidence rates of infertility and access to infertility care, as well as disparities in maternal health outcomes. And we'll be speaking about models of care that offer our communities the holistic, patient-centered care they need to make the reproductive decisions that are right for them, without fear of coercion or discrimination. Models like these are especially meaningful in light of this country's long history and continuing experience with reproductive oppression and human rights abuses, as we've seen very sadly in the non-consensual sterilization and other invasive gynecological procedures against immigrant women detained at Irwin Detention Center. We thought it was important to foreground our session with this acknowledgement, and we hope that it's helpful to you all in understanding how the issues that we are discussing are connected and how they impact the reproductive freedom of each and every one of us. So now I'll move on to the substance of my presentation, which is on infertility incidence and access to care disparities in the US. As Brianna mentioned, I'm Senior Human Rights Counsel at the Center for Reproductive Rights, where I lead our work on assisted reproduction in the US and includes our work on destigmatizing infertility and on making access to care equitable for everyone without discrimination. So here I want to focus on how infertility is defined and its scope. That is, how many people does it impact? The World Health Organization and the CDC both define infertility as a clinical condition, wherein a person is unable to become pregnant after 1 year of unprotected sex or to carry a pregnancy to term. Clinical infertility is a recognized public health concern that impacts millions of people around the world. In the US, according to the CDC, clinical infertility impacts approximately 12% of women ages 15 to 44, and almost 9% of men ages 25 to 44 report that they or their partner saw a doctor for an infertility issue. These numbers do not account for people who are socially infertile. Social infertility recognizes a person's inability to procreate via unprotected sexual intercourse based on their social circumstances. For example, they're single or in a same-sex partnership. So the scope of infertility is not well understood or documented, in part because it does not recognize social infertility, and in part because there is no concerted effort to really understand the number of people who are impacted by infertility in the US and globally. Recently, the International Committee for Monitoring Assisted Reproductive Technology developed a more inclusive definition of infertility, but the CDC and WHO's definition continue to only recognize clinical infertility. And this is consequential. I mention it because the CDC definition is often what's incorporated into US legislation that would make access to infertility care available and accessible for folks. It's also worth noting that clinical infertility is highly stigmatized. Infertility strikes at the core of the social expectation that women are innately born to bear children and become loving mothers. Any deviation from this norm, whether intentional or not, may not only engender societal stigma or personal shame, but also lead to societal isolation and result in high levels of anxiety and depression that mirror those experienced by people dealing with cancer and heart disease. In some cases, infertility may lead to marital or interpersonal conflict or domestic or intimate partner violence. Increasingly, infertility is also being recognized as a complex physical and mental trauma that's based on its negative personal impact on people's life expectations. Some characterize it as an invisible loss, a complicated grief process for involuntarily childless people. This is just background on methods of infertility care. Obviously, access to information and counseling is critical, knowing that you have medical help that can assist you in becoming pregnant and knowing where to access that information. Ovulation induction involves the use of fertility medications to stimulate the release of one or more eggs from the ovaries and is often used in conjunction with both IUI and IVF. IUI is also known as artificial insemination. It's a method of infertility care whereby sperm is transferred directly into a person's uterus to facilitate fertilization. This is often the starting point for many patients, though for others it's not medically indicated and they instead start with IVF. which is an assisted reproductive technology wherein sperm and eggs are retrieved and then combined in a laboratory to create an embryo that can then be transferred into a uterus where it may implant in the uterine lining. And then lastly, surrogacy. It won't be a part of this conversation, but just to note it, with the advent of IVF in the late 1980s, the incidence of surrogacy in the US has increased. And then surrogacy is the practice where an intended parent or parents contract with a third person to act as a surrogate to attempt to become pregnant, carry to term, and deliver a child or children for the intended parents using embryos that are created via IVF. In other words, the person acting as a surrogate does not contribute their own gametes to the creation of the embryos or embryo. So in our research, we've seen disparities in infertility incidence and in access to care rates. Unfortunately, though not surprisingly, there are documented disparities in infertility incidence rates and in rates of access to care. Today, I will be discussing disparities in these two, in incidence rates and also in access to care rates that fall along intersecting and overlapping lines of race, ethnicity, income, marital status, sexual orientation, and disability. So I'll start with race. Based on data collected from 1982 to 2010, the National Health Statistics Report from 2013 revealed that Black women are nearly twice as likely to be impacted by infertility than non-Hispanic white women. A more recent report stated that although Black women are 80% more likely to report infertility, so not necessarily be diagnosed with infertility, but self-report it, they're 20% less likely than white women to receive infertility care. And there are also below average rates of infertility care use among Hispanic and American Indian / Alaska Native non-Hispanic women. Infertility care can include a variety of services, like I showed in the previous slide, counseling, IUI, IVF. And I just want to note that IVF can be prohibitively expensive for many individuals and couples who need to pay for it out of pocket. A single cycle of IVF can cost upwards of $20,000, and that's per cycle. Often multiple cycles are required to achieve a live birth. So, it adds up. Indeed, a study found that nearly 34% of women discontinued their treatment after their first IVF cycle because of its high cost. And these high costs may also act as an incentive to patients and providers alike to transfer multiple embryos per transfer, which may lead to multiple pregnancy and attendant increased health risks for both the pregnant person and the fetus or fetuses, excuse me. Here is a map of what are known as infertility insurance statutes or mandates in the US, and this was updated as of this last legislative session. There are 17 states that have insurance laws or insurance mandates that require insurance companies to include coverage for infertility diagnosis and treatment in their policies. Of those 17, 13 specifically require that insurance companies cover IVF. And these mandates vary from state to state. There is no uniformity, but many of them include eligibility requirements that limit access. Many, for example, exclude small businesses, as well as employers who don't purchase insurance, but rather pay for health coverage out of pocket. Those employers are also known as self-insured employers. The best example of these kinds of employers is Walmart. Walmart is the largest employer in the US. It employs over 2 million people, including those employed at Walmart. There are currently millions of Americans that depend on self-insured employers for health insurance. Notably, under these mandates, the state infertility insurance mandates, insurance coverage is only available via employer-based health insurance. So Medicaid rarely covers infertility care, including IVF. And that means that the nearly 75 million people who are enrolled in Medicaid are often left to pay for any needed infertility care out of pocket or to forego it. A handful of the states that I included in the map in the previous slide also require that insured people use their, quote, spouse's sperm, without exception for single people, unmarried couples, or LGBTQ couples. Most all IVF insurance mandates also require a patient to prove clinical infertility, where infertility is based on physiological conditions, as I mentioned earlier in the presentation. For LGBTQ people, that means that they must demonstrate that they have tried to become pregnant by having unprotected sex for 6 months or a year, depending on their age. Such eligibility requirements are not inclusive of or sensitive to the experiences of single people and same-sex couples, who may be required to undergo instead 6 to 12 unsuccessful cycles of IUI in order to receive the required clinical diagnosis of infertility and then become eligible for IVF coverage. IUI is not as prohibitively expensive as IVF, but it can run into the thousands of dollars per round of IUI, depending on whether it includes hormone treatment and medical monitoring. And as with IVF, its rates of success are very low, and so multiple rounds are often needed to achieve a live birth. Fertility clinics and providers also act as gatekeepers to care. The American Society for Reproductive Medicine, ASRM, issues guidelines for member fertility providers in the US, but there is no overarching regulatory framework in place. And this means that individual providers who act as gatekeepers to infertility treatment may determine care for prospective patients based on criteria that may or may not align with ethical guidelines. In this environment, fertility clinics have reportedly denied care to single people, people in same-sex couples, people with disabilities, and other marginalized groups based simply on harmful preconceptions about who can and should be able to have children and parent. An example that the National Council on Disability shares is a case in which a fertility clinic denied infertility care to a blind woman based on the provider's perception that her blindness would present a direct threat to her future child. So one of the things that we have been advocating for is to situate infertility and access to care within the full spectrum of reproductive health care that includes access to contraception, abortion, and maternal health, to de-silo the work and the experience of infertility and access to care from the other forms of reproductive health care that we as individuals may throughout our life need access to each and every one of. We are also advocating for patients to receive comprehensive, unbiased, and evidence-based information about the care that they seek. As I mentioned, and as we all know, people have preconceived ideas and biases about who should and be able to parent. And in order to cut through some of those biases, we need to be able to provide our patients with the information that they need in order to make decisions about their reproductive decisions. We also advocate for states to establish or expand insurance mandates that are inclusive, so that get at the some of the barriers to care that I've mentioned in the presentation around requiring a clinical diagnosis of infertility, or that the patient use their spouse's sperm, for example, or that exclude small employers or religiously affiliated employers or self-insured employers. And then finally, to advocate for infertility care as an essential health benefit under the ACA, so that states can include it in their essential health benefit benchmark plan and make sure that patients who do not receive their insurance through their employer are still able to access the infertility care that they need in a way that is accessible, affordable, and equitable. Now I'd like to pass it on to my co-presenter, Brianna Lipscomb.
Thank you, Carla. That was great. So for my portion of the presentation, I'm going to focus on inequities in U.S. maternal health, and just note that a lot of this is really going to focus specifically on Black maternal health, because that is by and large the focus of my work, but also where we see some of the greatest disparities in maternal health in our country. So next slide. So first, what I'll do is give you all some background on just the data, kind of what the state of the problem is. But then I want to transition to, um, how all of our coordinated efforts over the past decade have really impacted the culture and the narrative around maternal health in the U.S. And then look ahead to what some of the challenges are that still present themselves, and perhaps what we can do, where the opportunities are in addressing those. So starting with the data, although the number of women who die in childbirth globally has really fallen in recent decades, the US rates have gone up. And the average maternal mortality ratio for high income countries is around 11 per 100,000 live births. But you'll see here on this graph that the US ratio is 26.4. So that's well above the average of 11 per 100,000 births. Globally, particularly for high income countries. So the high maternal mortality rate in the US is often blamed on the poor health of mothers, but a comparison with other wealthy countries undermines this argument. So similar wealthy countries with increased rates of cardiovascular disease, obesity, diabetes, and other conditions during pregnancy actually have lower maternal mortality rates than the US. Next slide. So this figure is showing the racial and ethnic disparities in maternal mortality over time in the US. And don't worry if you are like, what in the world do all of these arrows mean? I'm going to talk us through it. So what you'll notice, obviously, is that the Black non-Hispanic group is at the top of the chart, and that is not a good thing. So Black women are 3 to 4 times more likely to die from pregnancy-related complications and conditions than white women. And that risk is equally shared by all Black women, regardless of income, education, or geographic location. So in other words, the factors that typically protect people during pregnancy and support them for positive outcomes, those are not protective factors for Black women. Similarly, you'll see that the Native American or Alaska Native rate is pretty high as well. So that group also has a high maternal mortality rate, and they are 2 to 3 times as likely to die from a pregnancy-related cause than white women. And so I think what's important to point out is that Black women encounter numerous barriers to achieving optimal maternal health. And frequently the blame is placed on the individual person, but the barriers are actually structural, and they're exacerbated by increased medicalization of childbirth, which has been kind of an intentional effort over the past centuries, honestly, of childbirth and degradation of our social safety net. I think it's also important to point out that chronic stress due to the racial inequalities that make it more difficult for people of color to secure housing or employment, education, or freedom from violence, including freedom from police violence, has an impact on one's physical and mental health. And then we see that play out in health outcomes and even pregnancy outcomes. And then you couple that with constant threats to access to care, and we just see these issues become further entrenched. So, for example, I'm based in Atlanta, Georgia, and Southern state governments in particular have refused to invest in accessible healthcare and other public investments that contribute to healthy communities. And one example of that is the refusal of many states to expand Medicaid. And so instead, we're forced to make smaller steps like, okay, if you want to expand Medicaid more broadly, can we at least get you to extend the coverage period for pregnancy Medicaid? So these are the types of negotiations we're having to do because governments just simply aren't doing the more broad investments that we know can have positive impacts on health outcomes. I think that's all for this slide. Well, one other thing, I will say that, institutionalized policies are also preventing Black women, Indigenous birthing folks, people of color from accessing care. And when they do access care, the quality care delivered is questionable. And we really need to get at the root of that. So, for example, when it comes to maternal mortality and morbidity, folks love to say, well, did the person access care early? Did she get in, early for prenatal care? Well, so what if she did, if the care quality of care she received was not good? What good does it do if still when she presented to the hospital, the doctors did not listen to concerns that were raised? So these are the types of issues that we have to continue to address. It's not just about the provision of care, that's certainly a key piece of it, but are we assuring that the care delivered is of high quality? Next slide. So just really quickly, I also want to highlight that severe maternal morbidity is also a concern. So severe maternal morbidity includes unexpected outcomes of labor and delivery that result in significant short or long-term consequences to a person's health. And the reason that I want to highlight this is because severe maternal morbidity is actually 100 times more common than maternal death, but we often only talk about maternal death. And so severe maternal morbidity is impacting even greater numbers of birthing people. And this classification of severe maternal morbidity actually captures what we consider near misses. So thankfully, the person did not die, but it was close. And so we need to start thinking about maternal health much more broadly than just the devastating deaths that we're seeing, because there are certainly a lot of people that are, walking away alive, but with short or long-term health consequences as a result of their pregnancy. And so on this slide, it simply talks about severe maternal morbidity in New York during a specified period of time, and just talking about how the rates increased so drastically in that time, and that it's an issue obviously primarily affecting Black women, but that Puerto Rican women and other Latinas also had higher rates, and that those rates were highest among women living in high poverty neighborhoods. Next slide. So it is particularly frustrating that wide racial and ethnic disparities continue to persist in the US, because recent reports indicate that 60% of maternal deaths are preventable. And preventable maternal mortality is both a form and symptom of discrimination against women and birthing people. And it deprives birthing people of their right to live a healthy life. Reproductive rights violations are informed by and reinforce discriminatory stereotypes, practices, and ideologies, perpetuating discrimination against already marginalized groups. And so ensuring safe and respectful care at birth is a critical piece of the pathway forward towards racial and gender equity. Next slide. So over the past decade, there has been a coordinated effort by community-based organizations, national organizations, and the media to raise alarm about the Black maternal health crisis in the US. So in the past decade, there have been human rights reports by Amnesty International, my own organization, Center for Reproductive Rights. We have done them. We've done them in collaboration with Sister Song and National Latina Institute for Reproductive Health. Black Mamas Matter Alliance became a thing, in the past decade. And from there, we've seen so much from celebrities like Serena Williams and Beyonce, even talking about their pregnancy complications. Black Mamas Matter Alliance launched, I think 3 years ago, Black Maternal Health Week, which really was intentionally focused on shifting the narrative around how we talk about maternal health, and specifically Black maternal health. But the question remains, what has been the impact of all of that? Next slide. So we've seen a shift in language. So you'll see the set of words on the left. Traditionally, this is what you would see, this is what you would read, this is what you would hear when you talk about maternal health until recent years. So we talked about how just by you being Black, that was the risk factor for you having experiencing a maternal death, or because you're obese, other chronic diseases, you're unhealthy, just putting a lot of the responsibility on the person and not looking at the system more broadly. Whereas now there's more of talks of it's not that you're Black, is that you are exposed to racism, and that is having a physiologic effect on you. And also looking at the systemic barriers, there's acknowledgement now that disrespect and obstetric violence is a thing, that this is occurring, that this is the experience that birthing people are having, particularly birthing people of color, when they enter the healthcare setting. And a lot of that is driven by the implicit bias that exists from their providers. And then finally, this notion of resilience. And so putting more of a positive spin on how Black birthing people and people of color are trying to maintain some resilience in the face of all of this. Next slide. So there's also been a shift in visual depiction of Black motherhood. So you'll see the top set of pictures, which is, kind of going from sadness and despair to the lower set of pictures that we see more now is what I call Black mama joy. So we still have a long way to go to represent diverse family structures and mamas, but I would say that it's so much more uplifting to see that bottom set of pictures than the top set. All of the women are beautiful though. And then I'll just say BMMA and other Black-led organizations have really been intentional about the images that they use. And so hopefully that will continue to be a trend. Next slide. We've also seen a shift in community. So more birth experiences are being shared. There's a greater demand for accountability of both government and health systems. And we've seen an increased desire for community-based holistic care providers. So a shift from this expectation that everyone births in a hospital with an obstetrician to now more acceptance and more desire to have a midwife as a maternity care provider, having a doula as a support person, and even the notion of birthing in birthing centers or in areas that allow it, home births. Next slide. And we've seen a huge shift in policy, and I won't go in detail too much here because I think I'm already over time, but we have seen an unprecedented number of bills at the federal and state levels addressing maternal health, and even more specifically, Black maternal health. Now, sadly, we have not seen a lot pass. I think we're making baby steps there, but just the fact that I think just last year, there were nearly 30 bills in Congress that were introduced related to maternal health. That is huge because years before that, there may have been 1 or 2 bills. So there is certainly growing interest in this area and a desire for policymakers to do something. And I think communities are really holding them accountable to take action. Next slide. So we've seen a lot of progress in recent years, but there are ongoing challenges to addressing the maternal health crisis. Next slide. So I'll close out with these challenges. So one, some policymakers simply are not compelled to address issues involving racism, and we can't address maternal health if we can't address racism. So that's really like the #1 problem that we have. Funding is still not being allocated to organizations that are doing the work. Instead, funding to government agencies and academic institutions is being prioritized. Non-allied organizations continue to compete with Black-led organizations for ownership of the issue. So you have organizations that claim to have been working on maternal health for decades, and yet they never did it through a racial justice lens. And so now that more Black-led organizations are being amplified, there's this competition, this territorial spirit around the issue that is really frustrating me. And I know others that are really trying to advance maternal health through a health equity and racial equity, racial justice lens. Some messaging, particularly in the media, sensationalizes maternal death and perpetuates fear mongering. So some media outlets talk about the issue without identifying solutions or helping chart a path forward. So how do we continue to rally the community around this issue without making them terrified to give birth? Because re-traumatization is real. And I think that our media partners, and we need to hold them accountable to be responsible in the ways that they report on maternal death. And then finally, the last thing I'll mention is inclusivity. So maternal health is not only relevant to cis women, but it is relevant to trans folks, gender nonconforming individuals, and anyone else that identifies as a mama, whether they have given birth or not. So we really need to address that and figure out how we can better incorporate that into how we talk about these issues, even within our movement. So there's still a lot of work to be done, but I will stop there and turn it over to Dr. Nikia Grayson.
Thank you, Brianna. Thank you for that wonderful presentation that you and Carla both did. And I think it just really segues into really well into what I'll talk about, which is an example of an answer that we saw in our community to the infertility and maternal health issues that were plaguing our community here in Memphis. So I'm Nikia Grayson. I'm the director of midwifery at Choices Memphis Center for Reproductive Health in Memphis, Tennessee. And this is a picture of our new building. It's not the latest picture because actually it looks much better now, especially with the greenery that we have planted in the front. But this is a picture of our new 16,000 square foot comprehensive reproductive healthcare center. And like Brianna said, there has been an alarm that has been sounded around Black maternal health, but not just Black maternal health for us, but also reproductive health and reproductive freedom. And so we heard that alarm, and we in Memphis, specifically at Choices, decided that we were going to create a new model of care to address these issues that were happening in our community. So, you know, what did this little independent clinic in Memphis do? We decided to use midwives to bridge the gap that we were seeing in our reproductive healthcare clinics, and to create this comprehensive reproductive healthcare model. Memphis is the largest city in Tennessee, and it's located in the southwest region of Tennessee. It's bordered by Mississippi, and Mississippi, Alabama, and Arkansas. And Memphis at one time had the highest infant mortality rate in the country, and it continues to have the highest rate in the state. We know that Memphis is a predominantly African-American community, and that it experiences high rates of health disparities, and these health disparities are greatest in communities, you know, dealing with additional challenges such as unstable housing, low income, unsafe neighborhoods, substandard education, and you know these are realities facing many families and women and just people who live near the Memphis urban core. And so we also recognize that when we were looking at the issues around access to care, and like Brianna said, access means different things. So we're talking about, you know, they usually access is, okay, are there clinics in that city? Are there OBGYNs? Are there places where people can receive care? But is that true access? It's not true access to us if you cannot see the care providers that it is that you want. So that's really important to us. And that was really important to us. And when we decided to recreate ourselves in a new way in Memphis, we knew that the majority of the Memphis area OBGYN practices were moving out to the suburbs and to more affluent communities, and residents living closer to downtown and the urban core were more likely to be low income, non-white, uninsured or underinsured, and had less access to high quality care. And so also in our community, we recognize that African Americans and Hispanic women had higher rates of receiving late or no prenatal care, and of course, the infant mortality rates were highest among the Black families in our communities. And this was what we were seeing was that this rate was almost triple those of babies born to white women. And so we decided to reimagine how healthcare could be offered in this community, and to see how we could bring midwifery back to the community. A little history about Choices. Choices was started in 1974 as a first trimester abortion clinic. It was started as a nonprofit clinic, a feminist clinic. And at that time, for about 30 years, all it did was provide first trimester abortion care. And it was cash pay, and it had no other services. But through our evolution, we found that we could be an asset to the community and could offer more services than just abortion care services. And so the people who needed services, we went to our community to determine what it was that they were looking for. And we had many HIV positive patients who were coming to us in need of reproductive health care, to address their reproductive health care needs. Many of them were being cared for by infectious disease doctors who were only treating their disease and seeing them as their disease. And so we recognized that they still needed reproductive health care, but also needed to be treated as a whole person. They still had dreams of family and dreams of one day having families, and that was really important to us. We also recognized that we had a large LGBTQ community that was having difficulty getting fertility assistance because they were not seen as a traditional family. And so it was really important to us to provide some basic fertility services, as well as help our transgender patients with hormone therapy. And so this is how we evolved into the center that we are today. Next slide. So this is the typical model of reproductive health care, where some services are not as stigmatized as others, where birth and prenatal care is usually not seen as stigmatizing. Gynecological care is not usually seen as stigmatizing. But on the other end, transgender care, abortion, fertility assistance, those type of services are usually more stigmatized, and usually patients have harder times accessing those cares. They have harder time accessing transgender care, abortion care, and fertility assistance. So we decided to reimagine how it could be. Next slide, please. So this is how we see comprehensive care at Choices. We see it all as being care that is equal, and we envisioned having all of these services in the same place. The only one that we don't presently have in our clinic is the mental and behavioral health services, but actually we are working with local social workers and counselors to provide mental and behavioral health services in the future. But this is how we saw care. We saw reproductive care as being able to provide abortion care, transgender care, fertility assistance, HIV care and prevention, sexual health, contraception, and birth and perinatal care. I will say that we value all of these services, and we place no service above the other. So if you ever come to our clinic, you will notice that even in our birth center area, there are no pictures of pregnant women holding babies and or just babies, period, really, because we didn't want people to think that our midwifery service and our birth services were above our abortion services. So all of them are important, all of them are necessary, and all of them are relevant to people's reproductive health care along their whole reproductive spectrum. Next slide. So these are some of the barriers that we saw and some of the reasons we decided to add these services. We saw barriers to care, to abortion care, that were very similar to barriers of care for people who were researching birth options. So we recognized there were few available providers in terms of abortion care, but There are also few available birth options and providers, especially midwives in our community. In Memphis, um, there are very few midwives, and the few midwives that are available, especially if they're home birth midwives, all of them are white, all of them require cash pay, and this becomes very inaccessible to communities that are on Medicaid or TennCare, which is our Medicaid, and families who cannot pay out of pocket upfront for these birth services. We found that many families had to travel long distances for abortion services, and many had to travel long distances to access midwifery care. That there were many restrictions on abortion, many trap laws, which are the targeted regulations of abortion providers in our community, which we seem to fight daily. And there were many restrictions on birth options in the community as well, and birth providers and who you could birth with based on coverage through insurance. And in Tennessee, as most states in the South, Medicaid does not cover out of hospital birth, and it does not cover abortion services as well. And then, of course, there were restrictions on privileges for physician, hospital restrictions in terms of abortion care as part of the targeted regulation of abortion providers. And those same restrictions we saw in terms of midwifery care and the hospital restrictions on providing privileges to midwives in our community. And of course, there were very few providers in our community that will offer vaginal birth at the cesareans or the breech birth options. Next slide. So what are we doing to try to make this better, right? So like we said in the beginning, we built this comprehensive reproductive healthcare center, the first one in the country that provides not only abortion care, but it's midwifery led, it's Black midwifery led, and it provides birth services, prenatal care, birth services, and postpartum care. All of our patients have the option to birth in the hospital or out of hospital. We recognize that was huge because most people did not have that out of hospital birth option. We are purposefully, centering the experiences and insights of women of color, low income women, and the LGBTQ community. We provide comprehensive reproductive healthcare services, which include infertility services, which was really important to us because we recognize that many people, as Carla talked about it, are excluded from infertility services based on income, and all people should be able to access infertility services and be able to have the family that they want. And we are also working very hard to provide clinical training opportunities for student midwives of color to help build more community providers. But I think that, next slide, please. What's really important is that we are working to restore midwifery in the South. And we, like I said, we're reimagining how care can be provided. Choices is we're using the reproductive justice lens to really address the inequities and barriers that are issues for marginalized families so that they can access all of their reproductive options. We want it to be that we recognize that income inequality plays, like I said, a huge role in a person's in how people make their choices about not just abortion, but birth, and about their fertility care options. And our goal was to expand reproductive freedom, especially for those who have experienced reproductive oppression. And we know historically women of color have had their bodies violated, disrespected, and disregarded. And we are still seeing those same things happen today. With meeting people physically where they are and taking Medicaid and providing patients with education that could empower them and to help them to make informed decisions was a huge part of why we started to do this. So this is a picture of our team and the new center that we have started. Next slide, please. So we recognize that, like I said, we are a comprehensive center, and recognize also that we are fighting for birth justice for our Black and Brown families in our community. And this is the belief that a birthing person is empowered during pregnancy, labor, childbirth, and postpartum to make healthy decisions for themselves and their babies. And birth justice aims to dismantle inequalities of race, class, gender, and sexuality that led to negative birth experiences, especially for women of color, low-income women, survivors of violence, immigrant women, queer, and trans folks. Next slide, please. And as I told you before, our model is built upon the reproductive justice framework and explores how the ability of any person, explores how we can help any person determine their own reproductive destiny, and that it's linked directly to the conditions in their community. And these conditions are not just a matter of individual choice or access. So our options for making choices have to be safe, affordable, and accessible. And we found that reproductive justice offered a framework for empowering women, girls, transgender women, and it really helped us to create better, opportunities for our patients, so they can live healthier lives and in sustainable communities. Next slide, please. And so our model, our prenatal care model, is grounded, like I said, in that theory, but we provide high quality, non-judgmental care that's patient-centered. We recognize the patient is the expert of their body and a valued member of our team. And of course, we offer a hybrid model of care where we have individualized care, but we also do group care and community-based teaching, which is really important to us because we are trying to create a village and build up our community to be supportive of each other. We also offer a very robust postpartum care, and Brianna talked about in her presentation how a lot of the morbidity or mortality that is experienced by pregnant people is experienced really in that postpartum period. And so we recognize that it's truly important and being an important time to care for people. So most OBs will, you'll leave your OB's care after you've given birth, and they'll say, we'll see you back in 6 weeks. We usually see people at least 3 times in those 6 weeks. And we have a postpartum group to follow these families to make sure we can connect them with the care they need and address their social needs as well as their physical needs. Next slide, please. And I think that was it for me. I will say that we have created this new model, and we are excited about it and excited to see where it will go. And so I guess now we'll have our discussion.
Thank you all so much. I appreciate everyone that's been listening in. If you have questions, feel free to drop them in the chat box or the Q&A section, and we will go through those. We also have a couple of questions that we can ask ourselves. So as you all are thinking about what burning questions you have, Carla, I don't know if you have a question, you can kick us off, and I will start looking through some of the others that attendees are asking. You're on mute right now, Carla.
Sorry about that. Thanks, Brianna. Nakia, I wanted to ask about the model of care that you described that Choices uses, which I think is so necessary and refreshing. And I wanted to ask specifically about how you see that model being replicated in other cities and states, and why it's so critical that it is replicated in other communities like the one in Memphis.
Yeah, that's a good question. I think our model is an example of what you can do when you reimagine how care can be delivered. I think that we are kind of taught or believe that care can only be done in one way, and it can be done however we choose, right? And whatever it is our community needs. So our model, like I said, centers the most vulnerable in our community, providing all the reproductive healthcare options. We really are working to destigmatize, abortion and midwifery and out of hospital birth options, as well as providing, community with true choices, with true options. And to replicate this model, you really need to know that the community wants it, right? So I think that's where we started with a community needs assessment and a market study to really understand what our community wanted, because, the community really is the expert. They know what it is they want. We don't want to give them something that they don't need or don't want. And I would say that the next step is to know what the laws are regarding birth centers in your area. Some states require like a certificate of need to build a birth center. And so you want to know what those things are in your area. And also, something that is really important to me concerning our model is that we are a nonprofit clinic. I think that's really important to say, because this has allowed us to apply for grants and receive donations from funders and from our community. One of the things I'll say, like I said, Choices has been around since 1974, and we had never done a major fundraising campaign. We always did very small things, very small fundraisers, really just to cover our patient assistance fund, because if many of our patients can't pay for their care, we have a patient assistance fund that we would do fundraisers for, and maybe raise, let's say, $50 to maybe $100,000 a year. But when we decided to build this new comprehensive reproductive healthcare center, we realized we needed to raise far more than that. And so we did a major capital campaign, and we raised $6 million to build our new clinic. And so it is doable. But I think that one of the great things about us is that we are a nonprofit model. And so therefore it allowed a lot of funders to be able to pour into us and to buy into our vision, right? So, and that was really important.
Great. Thanks, Nikia. We have some great questions coming in. One is, what can organizations do in terms of benefits for their employees to help address some of these disparities? So Carla, I'd love to hear from you. I have some thoughts too on the maternal health side, but I'm also hoping that you can talk about it a little bit in terms of particularly those of us in the repro health rights and justice movement. How can our organizations better model what we should be expecting from organizations across the country?
Yeah, that's a great question. Thanks to Gerald who asked. So I think first and foremost, you need to start with a wide common denominator. There is no one model of a person who is impacted by infertility and needs access to infertility care. And so really consider, insurance is a really tricky area. I don't know much about it. In working with insurance providers and policy brokers, I think it can be overwhelming. But I think if you start with a core set of values about the care that you want your employees to be able to access, you can actually get a lot done. And if one of those values is that there should be equitable access and that it should be access without discrimination, then you take stock of who your employees are, or maybe in the future, and consider how you can make your policy as inclusive as possible, so that employees who are single, employees who have physiological conditions that now or in the future that may lead them to need access to infertility care, so that those are included in the policy that you are negotiating with your insurance provider. I would also say, one of the things that I think is really powerful is around destigmatizing infertility and making clear that this isn't just a health benefit, but it's also something that you as an organization, as an individual, as an organization can and should be aware of, and also offering other non-medical resources like mental health resources. As I mentioned, the stigma around infertility is really unfortunate and can really strike people very strongly, and can be very isolating. And so providing also mental health care services to your employees who may be impacted by infertility and need somebody to talk to about it is really important. The barriers that I mentioned in my presentation are just some of the ones that we've noted are really limiting access to care, but there may be others in your in your organization that you may want to take stock of as well. And if there's any further questions about what your employer can do, or you as an employer can do, feel free to reach out as well.
Yeah, so just to add to that, I think there are also policies that should just be standard around parental leave policies, making sure that folks have adequate time after delivery to recover and to bond and care for their baby. Also, we've been battling a lot of policies in Georgia and other states I know are also working on pregnancy workplace accommodations. And so making sure that, I think some of these don't necessarily fall into the benefits, Eric, part of the question, but maybe just what policies and practices does your organization have in place that support you in having a healthy pregnancy that, if you choose to carry it to term. And so, we're still seeing a lot of, companies that even if, a person is pregnant, they're still requiring them to be on their feet for their entire shift. They're not giving them additional breaks to go to the restroom and things like that. And so those types of policies that also address the culture around reproductive health and supporting employees and thriving, I think are also really important. Also, policies around being able to use your own sick leave to care for family. And so I think that's important, particularly in the postpartum period as well, that you have that flexibility to use your own time that you have earned and accrued to be able to care for loved ones. It's really important. So those are just a couple of other things that we're continuing to keep on our radar and encourage governments and organizations to adopt practices in that area. Nikia, I don't know if you had anything else to add to that one.
No, I think those are great. I mean, those are things that, we've done at our clinic. I think it was really important to us. I talked more about, our patients and patient care, but how we treated our employees was really important too, right? We wanted to model for the world what it was we wanted seen. So we did add paid parental leave and making space for them in our clinic to be able to pump. We have a lactation room, and we do allow for a lot of flexibility in terms of time and childcare, and offer, and especially during this time of COVID, when parents had to really change their plans in terms of staying home with them. We've been very, very flexible about that, understanding what their responsibilities are, and recognizing that in order for them to be good employees, happy employees that could really contribute to what it is that we're doing, that they had to have those things taken care of, right? And they needed to feel like we thought those things were important to us as well, and we do. And so we've made a lot of space for that, and offered a lot of flexibility as well.
Great. So shifting gears a little bit, there's a question about COVID restrictions, particularly the one around doulas. Some hospitals across the country, in an effort to figure out how to contain the spread of COVID early on in the pandemic, they were limiting not only the support persons across the board. So it could be the partner of the pregnant person, but also doulas. And so the question is, have there been any identified impact that these types of policies have had? So I will respond to that, but I also want to open it up to Carla and Nikia to talk about anything else related to COVID and how that impacts reproductive healthcare access more broadly. So we did see hospitals. I know in New York, we saw at least one in Georgia. There were also policies. I can't remember if it was New Mexico or on one of the reservations where they were, limiting or they were separating families just under the suspecting that, well, this patient is from this reservation, so they must have COVID. So we're going to separate the birthing person from the child. We saw all kind of policies that were arbitrary, fabricated, not evidence-based, take place throughout the pandemic. And I would say that we don't necessarily have hard data yet to demonstrate what the impact that may have had on some of the outcomes of deliveries. But what I will say is that it certainly threatens the safety of patients, and particularly patients of color, where we know that they're already at increased risk of providers having implicit biases and how that may play out in the delivery of discriminatory care. So, for example, and I mentioned earlier, you have what we consider disrespect and abuse, obstetric violence, where providers are not listening to their patients' concerns when they're being raised. And so if you put a patient in that situation, and then you've also removed that patient's support person that also could have been a voice and an advocate for them in a situation, then you are putting them at even greater risk for an adverse outcome. And so it was really important, not just to the center, but especially many of the community-based organizations that either provide doula care or recognize and acknowledge the value of doula care, to advocate against these policies. And many hospitals quickly reversed the policies once these issues were amplified in the media and folks were, made aware of what was going on. I would say the danger in it is that many of these policies were not necessarily written policies that had like a clear formula of when they were being applied. And so that's the other concern, is who's making these decisions, what's factoring into those decisions being made. And so these are the types of things that we've had to continually be aware of during this pandemic to make sure that hospital policies aren't being made that are going to further have negative impacts on communities of color or other marginalized communities, particularly as it relates to maternity care. But the other thing I'll say, and then I'll pass it off to Carla and Nakia, is that the same issues that we've been talking about forever as it relates to increasing access to maternal health care are the same issues that were just further exacerbated by COVID-19. And I think what's also frustrating is the communities that are most impacted by COVID-19 are the same communities that are most impacted by maternal mortality and morbidity. And so we've been saying for a long time, we need more access to doula care. We need better access to midwifery care. We need more respectful care. We don't need to have folks worried about whether or not they can pay for care. So these are the same things that we're still talking about within the pandemic. And it's just a shame that we didn't figure it out before the pandemic, because now our healthcare system is even further strained. So I'll turn it over to Carla and Nakia for any other observations they've had during the pandemic.
Sure, I'll just add that with regards to access to infertility care, in the US and in many other countries around the globe, many clinics did shutter and only provided care for people who were already, for example, mid-cycle. And so we're already on hormone medication, for example, and where completion of a cycle was important. I did mention during my presentation that there is no overarching regulatory framework or agency for infertility care providers in the US. And so many of them stopped their service provision based on guidance that was issued by the American Society for Reproductive Medicine. There were a few that remained open, but by and large, most closed or stopped providing services until at least that first wave was sort of mitigated. They have since reopened, and now with the rise in numbers, it's possible that they may have to close again.
So we have only a couple of minutes left, and there's two questions I want to get to. So I'm going to ask both of them. And I think, Nakia, these may be directed at you to respond. But of course, Carla, if you want to jump in, you can. So the first is, what is the best way to get involved in the support of patients, particularly for folks that don't have a medical background? And then the other one is, what role, if any, does destigmatizing teen pregnancy and teen parenting play into your work? So those are the two questions I will put out for you all.
Yeah. So you talked about how can people who are non-medical, I think you said, support uh, patients. I think that, and I think that question may have been asked by Brandy, and she asked a question also about coming into reproductive health care later. So, I'll answer both of those. So, one, I think that as a provider, as a midwife, I came to this as a second career. I did something totally different before. And it was important to me to do this work. I think you got to figure out where it is that you want to be, right? Do you want to provide direct support? Do you want to provide support in trying to help change policy? Do you want to do advocacy? Do you want to do education? I think there are avenues for all of those things. I think all of those things are very important. I feel like at our clinic, I have to do all of those things. Most people don't do all of them, right? Brianna is an amazing advocate, okay? And so she does really great there. Now I can do it, but I do it because of the uniqueness of our clinic in terms of being an abortion provider as well. So, but I like providing care, and before my work was really in public health and really dealing with creating intervention. So I think you have to figure out where it is that you want to be, right? If you want to provide direct care, you can definitely be a doula. You can do lactation counseling. You can be a community health worker, a childbirth educator. There are many things you can do. If you want to do the advocacy piece and the policy piece, especially if you're in the South, we need people fighting for Medicaid expansion. We need people fighting for people to be able to be on Medicaid longer. In Tennessee, they kick you off after 60 days. I know Brianna worked on legislation to help to extend that in Georgia. We need that help as well. You can advocate for comprehensive reproductive health care, in the South, which, majority of these states are abstinence only. But you asked also about destigmatizing teen pregnancy and teen parenting. It's very big for me. I think that historically, people want to punish teens for getting pregnant. And what has that gotten us? Absolutely nothing. They continue to get pregnant every year. I think we need to provide as much support as we can to teen parents. I think they are extremely resilient and they do well. Studies have shown they do well when they have support. We don't need to stigmatize them. We don't need to punish them for whatever decisions they made. Many of us have made decisions that may not have been the best, but I think with support and care and guidance and definitely, social and family and physical support, they thrive, they do well. So, so we work really hard. I don't believe in stigmatizing teens for being pregnant. I mean, we all are sexual beings, and I mean, we just need education.
And I'll just say, to the reverse of that, I think we really need to come to terms with how the culture around that and the stigmatizing of teen pregnancy has gone to the other extreme, where we have been so intentional. And I'm just speaking from my perspective as a Black person in the South. Don't get pregnant when you're a teen, go to school, get married first. And now I have a lot of friends that are mid to late 30s that can't get pregnant if they wanted to.
Oh, yeah,
and it's become very expensive, as Carla mentioned. So, the reverse of that is, how are we then exacerbating issues around infertility because people are afraid of what people think if they get pregnant too soon.
Right.
Yeah, I just want to add, the education piece, Nakia, that you mentioned is so important because, speaking from personal experience, I was told, like, do not get pregnant when I was a teenager. But I don't think that my parents ever, or even in my school, I was educated on what my fertility was, how I could better understand what my cycle meant, how I could best safeguard my fertility and how it declined with age. You know, I feel like you're so scared into not getting pregnant as a teen that you don't then get the other piece about like, what's the fertility window, you know, and when should you start thinking about if you want to have children, and if so, how?
It's not the end of the world.
Right.
Yeah. Yeah. And, you know, I was asked not too long ago what I would tell my daughter, you know, if I, you know, based on my own experience. And I told someone, I was going to tell her, have all the babies you want, me and your dad will help you with them. Because, you know, we waited, I was 38, you know, and it was a real problem. And so I'm going to tell them, have all of them you want, we'll help you, you know.
Well, awesome. Well, thank you all. I think we're right at time. Marla, I don't know if you need to close us out, or I certainly appreciate everyone's attention and their time, your thoughtful questions. Please check us out. So Nikia, what's your website? Is it just memphischoices.org?
They can read, memphischoices.org or nikiagrayson.com.
Okay. Okay. Awesome. And Center for Reproductive Rights, you can get us at reproductiverights.org. But please, you know, support the wonderful work that Choices is doing in Memphis, and figure out how you can replicate it in your own areas. I don't think it'll be easy, but it's certainly worth the try, because the things that you all are doing in Memphis are just wonderful, Nikia.
Well, thank you. Reach out, we'll help you.